Welcome to mpnuniversity.tv Clinical Insights. This discussion is about second-line therapy treatments for patients diagnosed with Polycythemia Vera and is moderated by Dr. Srdan Verstovsek and co-moderated by Dr. Ramon V. Our panel discussants are Dr. Stephen O., Dr. Elizabeth Hexner, and Dr. Jason Gotlib.
Polycythemia vera is one of the myeloproliferative neoplasms, traditionally considered rather benign because the life expectancy of the patients is rather long. And there are therapies that we use as a first-line therapies, hydroxyurea or interferon. But the issue today to discuss is what is the second-line therapy, and is there a room for development of new therapies in polycythemia vera? To start this discussion, let me ask you, Jason, what is your preferred first-line therapy for polycythemia vera, and when do you use it?
So when I approach a patient with PV, I first risk stratify the patient, and so the two issues that I consider are the age of the patient and whether they've had a history of thrombosis. And so generally speaking, if a patient is above the age of 60 or they've had a history of thrombosis, then I will consider the use of a cytoreductive agent to phlebotomy and the use of low-dose aspirin in the range of 81 to 100 milligrams per day. If a patient is low risk, then for those patients, the standard of care is generally low-dose aspirin and phlebotomy. So for those patients who, again, are older or have a history of thrombosis, I've generally used hydroxyurea as a first-line agent. And I would consider that if a patient was relatively younger, but may have had a history of thrombosis, those are patients that may be a candidate for cytoreductive therapy as well. And over the last few years, I've really pivoted toward the use of pegylated interferon. And part of that is driven by the issue of, although not perhaps statistically proven, they still remain a concern about the potential for leukemogenicity with hydroxyurea. We know that patients with MPNs have an inherent risk of movement toward acute leukemia. If you have a patient who's relatively younger and has decades in front of them, and with longer use of a drug like hydroxyurea, of course, for any particular patient, there is still a theoretical risk of a drug like that increasing the risk of leukemia, albeit not proven formally in studies. So I think that hydroxyurea or pegylated interferon are both reasonable options as cytoreductive agents as first-line therapy. I do think that if you have a PV patient that has severe thrombocytosis or other forms of myeloproliferation or increased splenomegaly that is otherwise a low-risk disease, there also may be a role for use of cytoreductive drugs.
So let's say that we have a therapy in place in a patient with polycythemia vera based on the characteristics that you described. And there is a need for a change. A toxicity develops or a lack of response. Would you then alternate between the two? If the patient was started on pegylated interferon, you would then go to hydrea and vice versa? Or would there be a role for exploring something else based on patient characteristics?
So, we all know that, for example, the JAK inhibitors are trialed in patients with PV and ET. And we know from, for example, the data from the RESPONSE trial that in patients who are hydroxyurea intolerant or resistant, and we can talk about what the definition of hydroxyurea resistant means, that the trial did show that there was better control of hematocrit and need for less phlebotomy and also control splenomegaly. So I think there is a nascent recognition that there could be very well a useful role for JAK inhibition in patients with PV, and again, in the second-line setting. So I'm looking forward to seeing whether agents such as ruxolitinib get that approval, and also there may be a role for other JAK inhibitors for second-line therapy for PV as well.
Now, Elizabeth, what would be, in your experience, the most common reason for changing from the first-line therapy to something else? Is it intolerance? Is it patients don't like it to take it, despite the success, like a low-grade nausea or vomiting, or low-grade fevers with injection of interferon, or mouth sores with hydria? What would you say, when is the need, and what would be the most common reasons for change?
So probably, I guess a lot of what I do is just troubleshoot sometimes the toxicity. So sometimes we can continue on the same therapy and just adjust dosing of hydroxyurea, for example. I actually, I have the same concerns I think we all do about long-term exposure for hydroxyurea in the younger population. And also with pegylated interferon, there's a real interest in it being actually disease modifying and the achievement of complete molecular responses in some patients. So I would say that, to answer your question, I think one really common reason is patient preference, actually. And the other is probably cytopenias or some issue. I think the challenge actually are the people who are having clotting events, for example, in the setting of hydroxyurea, and sort of knowing where to pivot them.
So you are defining one of the reasons for stopping therapy, really a progression, or not a control
Failure,
of the risk.
yeah.
The goal is to prevent the clotting, right? And you have the episode. But there is a large group of patients that are treated with the hydroxyurea from the retrospective analysis that have a good response, but not good enough, that are maintained on a hydroxyurea for quite some time because there are no alternative options. We know all the papers from Spain talking about this. Stephen, what's your experience with such a group of patients? It seems that this is almost a half of the patients that have a response but have some low-grade toxicities, and we don't have much to offer. How do we define a time or a reason for a change?
So if I can, I want to sort of back up a second
please.
and sort of talk for a second about going back to the first line treatment. And I think there's certainly a lack of consensus on the use of phlebotomy versus hydroxyurea or perhaps interferon. We know the guidelines, as Jason outlined, for high-risk patients, but I'm sure you all have in your practice patients who are high-risk simply by age. So, for example, say a 65-year-old patient who has had no history of thrombosis, and then it becomes a question of does this patient actually need to be on cytoreductive therapy at all? So I think that is something where we don't have clear data from randomized studies as to whether cytoreductive agents are superior to phlebotomy, or what happens, I think, in a lot of cases from a practical standpoint is you start phlebotomy, then you may add in hydroxyurea at some point. So I think that first point is still up for debate in those types of patients. But to get at your question about toxicity and whatnot with hydroxyurea, in my experience, I think that the intolerance, or at least patients' conception of intolerance to hydroxyurea, is much more common than true resistance to hydroxyurea. You can get at what is the definition of that, but in my experience, it's much more common for patients to be intolerant to hydroxyurea. True resistance to hydroxyurea, in my experience, is very uncommon. The dose can be pushed. Most patients, you can control their counts if you push the dose high enough, and then the question is what dose is too high. But I would say more commonly, I find that some patients just simply have toxicities.
And I assume we are talking about the low-grade toxicities that they can actually sustain for some time, because this is that group of patients that may have occasional mouth sore. You can push the dose much more because they will have more. You control counts to some extent, occasional phlebotomy in place. So you have some response, and it's good enough. But there might be a need for some better agent.
Right. So you may, find yourself, again, from a practical standpoint, titrating the hydroxyurea, perhaps not as high as you would like it to get the response you would like, but because of toxicity, be willing to, say, accept a hematocrit or whatnot that is not exactly where you want it because of the toxicity. So there is definitely that area where it's a bit of a problem.
And then there is an area of a loss of response. There are patients that get worse. The spleen starts to grow. For some reason, the red blood cell counts to grow again. They have a lot of symptoms. Clearly progression, if you like, in just regular PV. Not progression to or transformation to myelofibrosis, but just progression. So in that situation, is interferon then the second line, or is it based on patient characteristics, age? We'll use busulfan if the patient is 70 plus. Anybody using radioactive phosphorus? What do we do?
Yeah, I think that, well, first of all, I tend to, of course, stay away from radioactive phosphorus, and that should be reserved for patients who are refractory therapies and, frankly, much older because of its known leukemogenic risk.
I agree.
And so, you know, the patient who's having progressive splenomegaly or they're having uncontrolled counts and they are not histopathologically confirmed as myelofibrosis, I think this is an area of unmet need. And I think that one's options are increasing the hydroxyurea dose. I think that there may be age-dependent opportunities here for use of pegylated interferon. Again, there are opportunities for perhaps moving toward more traditional agents like busulfan. At the end of the day, such approaches, such as busulfan, I would think, like Hydrea, are more cosmetic. And you always have to weigh the issue of potential benefit and side effects, and the issue with pegylated interferon, particularly in an older population which may have more comorbidities, is really confounded by that issue. You know, you really need to seriously consider whether older patients with comorbidities are going to tolerate a drug like pegylated interferon. And so again, this goes back to the issue of the role of a JAK inhibitor, which you know, these drugs have a non-hematologic profile that seems to be overall very good, and this is where there's an unmet need for drugs that mitigate symptomatic splenomegaly, can improve disease-related symptoms. And so I think this is where the field is moving for patients who are resistant to conventional agents.
So far we had 2 publications on 2 different JAK2 inhibitors. And Elizabeth, you were first author on one of them. In general, for the audience, how would we define a good JAK inhibitors for use in PV patients?
So I get, you know, I think critically important is the tolerability of the medication. This is I agree with you, sort of a patient population that's probably got a burden of disease that's under-recognized, but still they're generally a healthy patient population, and you don't want to ruin their lives with toxicity. So tolerability is very important. You know, I think we would all love something that's truly disease modifying, something that could actually reverse the disease in some way. But I guess that those would be the major.
So efficacy for sure, right? And
Yep.
then tolerability so that you can provide this for many years.
Yep.
But your point is well taken, disease modifying. From myelofibrosis, we have a lot of discussion what the disease modifying actually is.
Yeah.
With the interferon, and Jason has mentioned this before, and you too, we have molecular responses, and you mentioned that too, where we cannot detect JAK2 mutated cells anymore in patients on therapy. Yet the clinical benefit in normalization of the blood cell count and possibly decreasing the risk of thrombosis, unproven as of yet, does not correlate with the molecular responses. How do you look at that, Stephen?
Well, I mean, I think that's an important point because I think to some extent we're all impressed by the fact that some patients treated with interferon can have a molecular remission, but we just don't know what the long-term significance of that is. And so, from a practical standpoint, my experience is that patients, though some patients are sort of very interested in that that idea that they could potentially have a molecular remission, that there's often, on the other side, a reluctance because of the potential side effects of interferon. So when it comes to second-line therapy, for my practice, assuming that they've already been on hydroxyurea, it boils down to interferon, a JAK inhibitor, whether that's potentially ruxolitinib off-label or a clinical trial with one of the other JAK inhibitors or some other novel therapy. So again, as we have already discussed, you have to think about tolerability as well as efficacy. And given that these patients, though they do have symptoms, their overall clinical status and prognosis is much more favorable than, for example, myelofibrosis. The use of JAK inhibitors in this patient population has to be viewed very differently than in myelofibrosis.
Have you noticed a difference in tolerability based on age with regards to pegylated interferon?
Well, to be very honest, I've tended to stay clear of using pegylated interferon on older patients. I would say that I do have a cohort of patients that I've tended to use interferon in that are in the age range of 30 to 50 years old, and it's my mantra is low and slow. So
Yes.
it's a low
Yeah.
dose. It's dose escalating, from 45 micrograms per week, and if it's well tolerated, but I'm not quite getting the control that I'd like to see, then I'll move to 90. Usually, I can get what I want with good tolerability at 90 micrograms per week, and I really needed to go much higher than that. And this is borne out from the studies from the French Jean-Jacques Kalajian and the MD Anderson group in terms of the fact that, of course, at higher doses, there's just substantial intolerance. So start low and see what the right dose is regarding efficacy and tolerability.
Traditionally, we judge the efficacy of the therapies by looking at their real reduction in the risk of thrombosis. Hydroxyurea was actually tested in a phase 3 randomized study, and cytoreductive therapy, therefore, by decreasing the red blood cell count, would decrease the risk of thrombosis. We all assume that that's the case. Do you see a need for any other therapies, being interferon or a JAK2 inhibitor, to really prove that point? Or is it good enough to say that normalization of the hematocrit is a surrogate marker for such an event to decrease the risk? Because we are not just talking about benefit on the red blood cell count with JAK2 inhibitors, we are talking about reduction in the spleen, in the symptoms, white cells and platelets. What's your view on a need for ultimate proof?
I would love to see it, but I think I just think the event rate is relatively low. I think it's an impossible.
Takes time.
It would be an impossible question to actually ask. But.
And the molecular response, how important is this in every practice? You already alluded that might not be the case. Yet there are patients on interferon that are obsessed about us as a doctors measuring the JAK2 allele burden. And I keep telling them that's not the ultimate goal of therapy. I don't know what that means.
Yeah, I mean, I think those of us in the field have recognized for some time now that these diseases are, for lack of a better characterization, not as simple as, for example, CML in terms of molecular monitoring for BCR-ABL versus JAK2. So the meaning or implication of the allele burden dropping or going down to zero is we just don't know. I think it's more complicated than simply wanting that number to disappear.
Do you even measure it, actually?
If I measure it, it's more out of sort of an academic interest than any real clinical utility. So it's not something that I really put any true clinical significance on.
How about you, Elizabeth? Do you
So there's
routinely
also the
measure?
question of when to stop,
Yeah.
or whether they need it perpetually. And so I've checked it, yes, I have. I confess. Sometimes at about year 2, I'll have a look.
But not necessarily to kind of change therapy, but more out of curiosity than anything else.
Sometimes to interrupt therapy if they've had a complete hematologic response for a while, and they're paying $700 a month for the agent if they're in a complete molecular response. But I'm not saying that there's data supporting that.
So it seems to me that we all agree that there is a need for something new in patients that are not doing well on a frontline therapies. They may be switched from one to the other. There are issues here to discuss about tolerance, long-term toxicities with hydria or additional chemotherapeutic agents. And there is this preliminary result that Jason, you mentioned in a randomized study of ruxolitinib versus best available therapy in the second line, that gives us hope that there might be really clinically relevant outcome from these studies for patients to benefit from JAK2 inhibitors if it gets approved. Is this the role for the JAK inhibitors, really just the JAK2 inhibitors for the second line? You see it as such, or is there something more that we need to explore here to change the natural course of the disease, combination studies later on, or where is the field going?
Well, I would, one wonders whether one could do a study with reasonable follow-up that does capture a different event rate with regard to thrombosis. So, I could imagine, again, whether it's feasible, one would have to see, doing a frontline trial where you include high-risk patients that perhaps are at a higher risk of thrombosis, and they're randomized to standard therapy as a cytoreductive with hydroxyurea or a JAK inhibitor, and because you do want to see a concrete endpoint such as decreased rates of thrombosis, and that would be a very compelling story, I would think.
Or how about even maybe when we define high risk, patients who had a prior thrombosis, and would they have a recurrence?
Exactly. I think that would even be yet more compelling because those are patients that yet may have a higher risk of thrombosis within a reasonable period of follow-up, whether it be a couple of years or so.
Are we able to define the high-risk patients based on the molecular findings? High allele burden? Are these candidates for certain interventions, even if by the conventional therapies, conventional risk assessment, they are not high risk? Is it time for that, or not yet?
I don't think so.
Not yet?
I don't think there's clear enough data on that.
Okay.
I mean, the data that was published by Dr. Vera, does not yet incorporate molecular markers, but it's an issue of age and leukocyte count, prior history of venous thrombosis, and karyotype. Like what we are doing with myelofibrosis, where we're combining the traditional risk factors that are included in the IPSS or TIPS Plus with the new molecular data. I would like to see whether we can incorporate the molecular data with the risk models that have been published by the Italians and the Mayo Group. I think that would be very useful because we do know from, for example, the MD Anderson study that looked at pegylated interferon, we know that responses seem to be less robust if there are additional mutations beside JAK2, such as TET mutations or other genes that are mutated. So I suspect that there are less types of mutations in PV. It seems to me much more of a cleaner genetic disease compared to, of course, myelofibrosis. But if you get large numbers of patients and analyze it together with additional risk factors, there may be a role for that in the future.
So it seems to me that it's safe to say that there is obviously a role for another agent like a JAK2 inhibitor if it's safe and effective as a second-line therapy, where we really need something to offer to the patients that failed the first-line therapy. And the future will see whether we can identify high-risk groups in a proper way and extend the use of these novel agents even in a frontline setting. So I would like to thank you all for a lovely discussion on the topic of a second-line therapy in PV, and thank you very much for participation.